in 1805, and he did the operation twice. Both of the patients died, but he realized that it was a step in advance and recommended it for all cases requiring abdominal delivery. The mortality of the classic cesarean section has improved as time has gone on, and it did not seem that we needed a better method of abdominal delivery. But our ideas of what was good also improved. In 1870, the mortality of 15% in cesarean section was not bad. In 1900, the mortality of 4% was considered excellent. In 1930, a mortality of 1% is too much. Therefore, when in 1906, Fritz Frank of Bonn introduced the operation of Osiander, the low cervical incision, it was eagerly seized by the German operators, and its use has been spread over Europe, and now in the United States it likewise is receiving recognition. The principle of the new operation is that the incision is made in the lower uterine segment, the neck of the uterus, and not in the fundus. And all the superiority of the new operation grows out of this fact. There are two kinds of low cervical cesarean. One where the incision being made just above the pubis, approach to the lower uterine segment is gained by cutting through the peritoneal cavity. It is called the Intraperitoneal Method. The other kind is where the incision is made just above the pubis and the peritoneum is pushed upward towards the navel off of the bladder, and the bladder is pushed to the side and an area of lower uterine segment exposed sufficiently large for the delivery of the baby. This is called the extraperitoneal method, the general peritoneal cavity not being open. The majority of men prefer the direct route, the intraperitoneal method. The indications for the low cervical cesarean section are exactly the same as for the classic cesarean section. But owing to the safety of the low operation, we can extend the field in which it may be done. Now, it is a fact that in the United States, too many cesarean sections are being done. And it is also a fact that if the new operation were generally practiced, the total number of cesareans done in the United States would be reduced. I shall have occasion to refer to this point later on. The contraindications to the operation are very few. In a woman with a pendulous belly, it may be hard to get access to the lower part of the abdomen to make the incision. And if you are going to do a paro, it is hardly worthwhile to do the low operation. But if at any time you have to do the old classic, make it as low in the uterus as possible so as to get as many of the advantages of the low operation as are to be had. Now a few words about the surgical anatomy. Here is a model of a woman at term but not in labor. Here is the cervix, and here the lower uterine segment, which is about 9 centimeters long. This is variable, but it nearly always is long enough for you to extract the baby through it. Here is the loose peritoneum over the lower uterine segment, and here is the fascia, this white line, the fascia that extended from the vagina upward and loses itself towards the fundus of the uterus. It is about this point that the gray seam is located. You will hear a great deal about the gray seam during the operation. Here is a model of a woman who has been in the second stage for a long time. And you can see how long and thin the lower uterine segment and cervix are. They are fully 15 centimeters long, and the lower uterine segment almost invites you to cut into it. When you do your first low cervical, select the case where the labor has been on for a considerable length of time, and that makes it much easier. You see how thin it is. Here is the peritoneum again, and here is the contraction ring. Now, gentlemen, a few words about local anesthesia. It is particularly well adapted to the low cervical cesarean section, and I prefer it to spinal anesthesia, indeed to general anesthetics too. No one can deny that spinal anesthesia is more dangerous than the local infiltration, and since we can, in 90% of the cases, succeed with local infiltration anesthesia, this should be the method of choice. And I have here in my hand the instruments that we use at the Chicago Lying-In Hospital. They facilitate the operation, but ordinary syringes will do the work just as well. We use Novocaine, procaine solution, 1/2 of 1%, and we add 2 minims of adrenaline to every ounce of the solution. We use 7 or 8 ounces, sometimes 9 or 10, and we have never had any cases of poisoning or any trouble whatever. After the baby is born, 1/4 of a grain of morphine and 1/150th of scopolamine are given. Solomon said that you should have an understanding heart, and this will help you a great deal in your operating under local anesthesia. No tugging, no pulling, no jarring of the patient. Gentleness all the time, and you will succeed. Now, gentlemen, let us proceed to the amphitheater where we will do the operation. Now, Mrs. Herman, we are ready to start. Don't be afraid. It will hurt just a little when the baby comes. I'll prepare you. If any of my work should give you pain, stay out, but don't move. Pubis. Navel. We use a very fine needle to make a wheel in the skin. Then the big needle doesn't hurt when it goes in. Inject the Novocaine into the skin itself. And, of course, into the fascia right under the skin. Inject as you move the needle in and out. Do you feel that?
No.
Do you feel that?
No, Doctor.
That's good. We're going to see the gray seam where the loose peritoneum of the uterus becomes firmly adherent. See how loose it is here? But I prefer the scissors. On this drawing, you see where the clamps go and how the scissors cut the lower uterus at the front. On this pelvis, you see how the forceps are to be applied and the head delivered. See the hammock effect of the forceps. Slowly, no hurry. Now, Mrs. Herman, the baby is about to come. Be brave, don't squirm, breathe quietly, and in a very few moments, you will hear the baby cry. I am putting my finger in the baby's mouth to bring it to the front. Be careful, you can injure the little mouth. Wipe out the baby's mouth, because if it's gasped, it might suck in like ramniite. Slip the forceps blade under the lip of the wound. Be very careful of that. Take lots of time, very slowly and gently. All the instruments have been removed from the wound. Slow. Take lots of time. No hurry. Be ready to take the baby bait. It's common when you have a lap plunge end. Now, Mrs. Herman, you go to sleep. You have a fine, healthy baby. And also, you've had a hypodermic. Gentlemen, we will now proceed to the repair of the wound. In this animated drawing, which Mr. Carlson made, you will see the course of the suture. Avoid the mucosa. Swing the needle around. Now, in the upper part of the uterus, the muscle is much thicker and is likely to retract up into the body of the uterus.
What kind of suture material do you use, Dr. DeLee?
We use number 2 catgut for the first row. The second row we use number 1. And for the peritoneum, number 1. Very important to get a good apposition here in order to have a firm scar in the lower portion of the fundus and the cervix. Don't catch the gauze in the needle. Pull it out a little, David. The complications of the third stage. Very seldom is there postpartum hemorrhage in laparotrachelotomy, especially if you use local anesthesia. And we give ergot 15 minutes before the baby is born and a hypo of pituitary right afterwards. If there should be hemorrhage, we pack the uterus, but I do that as a routine. And if you want to give pituitrin, as it's necessary, inject it under the peritoneum as I put it under the peritoneum because if the solution is infected and makes an abscess, the abscess is not opened into the peritoneal cavity. Some accoucheurs believe that placenta previa is not a good indication for laparotrachelotomy. But our experience in 40 cases without mortality proves the contrary. There are 3 or possibly 4 things that must be remembered. In the first place, in anemic cases, precede the operation by a transfusion of blood. And second, save blood throughout the whole course of the operation. Don't waste any. Third, deliver the baby by version and extraction and proceed slowly so as not to do any tearing. Fourth, clamp all the bleeding vessels and hold them securely clamped until they are sutured. Now, gentlemen, do not fear the difficulties that you might encounter. The field is open before you, and you can meet the emergencies as they arise. The hemorrhage you can control by the ordinary proved surgical method, and mechanical difficulties are overcome by taking time and by art instead of strength. Let me again recommend the low cervical cesarean or laparotrachelotomy as well as local anesthesia. Any of the difficulties an ordinarily skilled surgeon can overcome. And if you will perform this operation as a routine, I am sure that you will cut your mortality in half. What are the particular features of the low cesarean that make it so superior? As I said before the operation, these points of superiority grow out of the fact that the incision is in the lower uterine segment. And I will now give you 10 of these points of superiority. The first point is that the incision is in the lower part of the abdomen. All the surgeons know that the lower abdomen is more resistant to infection than the upper abdomen. The intestine and the omentum rarely come into view and are not touched. Therefore, shock is small and there is less tendency to vomiting after the delivery and to ileus. The spill is located right around the wound and has very little distribution, which also helps prevent shock, ileus, and nausea and vomiting. The cervix, in which the incision is made, is more resistant to infection, being used to it. Every gynecologist knows how much the cervix can stand. I will now show you this on another chart. This chart shows the delivery, shows the uterus a few hours after delivery. As you see, the cervix shrinks and drops into the pelvis out of the general peritoneal cavity. That was point 5. Point 6. In this chart, you see the uterus a few hours after delivery. And as you will notice, the wound in the cervix has dropped down into the cavity of the pelvis, far away from the general peritoneal cavity. That was point 5 in the list of superiority. One of the greatest advantages of the low incision lies in the security of the scar in subsequent pregnancies and labor. Only a few cases of rupture of the scar during pregnancy have been put on record, and the number of ruptures of this scar during actual labor is only a small fraction of those that occur after the classic cesarean section. The reason for this security from rupture is easily seen by a reference to these charts. In this operation, the wound is in the lower uterine segment, which is at rest and can heal in peace. It is not disturbed by the turmoil going on in the fundus above. Compare that wound with this after the classic cesarean section. Here, the wound is in the fundus, which is in a constant state of unrest. The uterine contraction, the after pains, keep up a constant motion, and sooner or later, one of these stitches or more than is safe will tear and let the pus, the lochia, and bacteria into the wound and into the peritoneal cavity. Point of superiority number 7. In the old classic cesarean, the lochia has a chance to seep through the uterus into the general peritoneal cavity, causing peritonitis. In the new operation, the low cervical, the lochia is prevented from seeping through and is confined to the neighborhood of the cervix and under the bladder. Should infection occur, which is not common, see how easy it is to drain the area that is infected. Either you can pull the cervix down with a valcellum and make an anterior calpotomy, thus reaching the abscess under the bladder, or you can burrow a finger through the stitches into the abscess, or what is most common, nature helps you in that the pus burrows under the bladder, around the bladder, through the cavity of Rhesus, and by taking out 1, 2, or 3 of these stitches, you can let the pus out, and usually healing is very rapid and complete. For comparison, see where the infection would travel after a classic cesarean section. Beginning here in the endometrium, all through the peritoneal cavity. Adhesions are common after the classic cesarean section, and the reason is very plain. When the infection and pus the intestines and the omentum. On the other hand, after the low operation, adhesions are very rare, and you can see why. The wound is dropped down into the pelvis, far away from the general peritoneal cavity, and the omentum almost never comes down so low, the intestines hardly ever, and when the bladder fills, the peritoneal line of suture, that little line of suture I showed you at the operation, drops down into a deep cul-de-sac and is further protected. Finally here, but there are many other reasons. The classical cesarean section is only safe when it is an operation of election. We can give a woman a good test of labor and then perform a low cervical cesarean section. And therefore, by giving a woman a test of labor, a great many cesareans will be unnecessary. And thus, the total percentage in the United States will be reduced. Now, gentlemen, in conclusion, I have here the mortality statistics of the United States Census Bureau in Washington. And from these tables we can learn that over 500 women die from cesarean section every year. This is an enormous number and brings upon us the opprobrium of the community when our statistics of maternal mortality are compared with those of other nations. If laparotrachelotomy was generally practiced in the United States, I am sure that most of this mortality would be reduced. And this is the reason that I have spent a great deal of time, a great deal of effort, and not a little money in spreading the gospel of the low cervical cesarean section or laparotrachelotomy. Ladies and gentlemen, it is now 6 years since the picture which you just saw was published, and I am going to tell you what has happened to the operation laparotrachelotomy during this time. But first, I want to show you those babies. Boys, will you come in? I believe that Caesones do better mentally and physically than children delivered from below. Attention, salute, left face, march. What has happened to the operation during these 6 years? Several modifications have been suggested, and we have tried them. But we have found that the method which you saw on the screen and which was perfected after 14 years of trial is still the best. For example, the transverse cervical incision, like this. A transverse curvilinear incision is made above the bladder. We tried the operation 10 times and gave it up. One severe hemorrhage from the base of the broad ligament. One dangerous extension of the wound, a big baby. Twice difficulty in suturing the upper to the lower flap. The upper muscular lamellae had retracted into the fundus of the uterus. And one almost fatal pulmonary embolism. The literature records the fact that there are more pulmonary embolisms after the transverse incision than after the longitudinal. We had one embolism in 10 transverse incisions, and we had only one embolism in the 1,800 other laparotrachelotomies. The surgeons or gynecologists would be very happy if they could record 1,800 consecutive laparotomies with only one pulmonary embolism. This is the median incision. If the baby is large, you can extend it up or down towards the cervix. If a tear occurs, it does not go into the bases of the broad ligaments where the big vessels and the ureter are. If the wound should get infected, the dangerous areas, the big veins, are far away. Doctor, do you still use packing? Oh yes, we pack the uterus routinely, but we are now using acrylflavin, iodine, and glycerin on the gauze. I wonder if there really is an antiseptic that does good. But we have a better ergot preparation. It is called ergonovine. Regarding post-operative adhesions, we have done second and third laparotrachelotomies on 345 patients, and we found adhesions to be the exception. Whereas, after the classic cesarean section, adhesions are the rule, and they not seldom cause serious late complications. Fertility, likewise, is not compromised by the low operation as it is by the classic. Rupture of the uterus in subsequent pregnancy and labor. The cervical scar has proven its superiority. There are only 3 cases on record of rupture of the scar during pregnancy, and during labor there are less than 50 cases on record, whereas the classic cesarean is notoriously dangerous in this respect. There are thousands of ruptures to its discredit.
Doctor, how about placenta previa?
We have done 120 laparotrachelotomies in placenta previa without a single death. Some doctors claim that the classic cesarean section is better in this complication, but we believe just the opposite. We want to make the opening in the uterus over the bed of the placenta, where we can attack a hemorrhage should one occur. You make the incision a little bit higher on the uterus than usual. The bleeding is only marked if the placenta happens to be on the anterior wall. You burrow through the placenta, grasp the foot, and slowly bring the breech into the opening, just the same as you do when delivering from below. If after the placenta is delivered, the bed of the placenta bleeds, you simply sew it up, like this. You see, it is very easy to stop the bleeding. You whip over the bed of the placenta with number 0 catheter. Regarding infected cases, we have not broadened the indication for laparotrachelotomy to cover the frankly infected case. But we have risked it even when the bag of waters has been ruptured a long time, when several vaginal examinations have been made, when labor has been prolonged, and when forceps has been attempted, providing there was a reasonable amount of cleanliness. The Paro operation is still the best for the frankly infected patient. But, although it is sad to have to say it, craniotomy may still be considered in rare instances. Local anesthesia. Local anesthesia has helped materially to reduce our maternal mortality. It is better than spinal in every way, and even the neurologists are telling us of late diseases resulting from this invasion of the spinal canal. Laparotrachelotomy is the ideal cesarean, and experience the world over has justified all the claims we have made for it. You remember I told you that it would cut your mortality in half. Well, look at this chart. City of Chicago, 1934. 490 classics, deaths 5.5%. Laparotrachelotomies, 541, 2%. Germany, classics 438, deaths 6 4/10%. Laparotrachelotomies 3,554, deaths 3 7/10%. Chicago Lying in Hospital 1914 to 1936. Out of 60,000 deliveries, classics 168, deaths 6%. Laparotrachelotomies 1,811, deaths 18 from all causes, tuberculosis, eclampsia, heart disease, etc., 1%. Now, ladies and gentlemen, a final word. I believe, in view of all these facts, that I may, in all fairness, ask you this question. Does a man, in performing the old classic cesarean section, when the low cervical operation could be done, does he give his patients all the benefits of modern obstetric art?